Thank you so much.
Thank you, Hindi team. Thank you, Dr. Abhishek Singh. Now we are moving to the English session. Today is our 1699th day of continuous webinar. Welcome all the participants for today's session. Now we'll start with a silent prayer. Good evening and welcome once again. Thank you all the participants for joining with us. Today's our speaker is Dr. Shailendra Bhamar. He's MD in Homeopathy. He's working as a HOD in Department of Practice of Medicine, Homeopathy College, Rajkot, Gujarat. And he received many awards like Medica Excellence Award, Materia Masters Award, and published more than 25 articles and more than 19 years of clinical and teaching experience. You are welcome, sir. We are happy to get you as a
Thank you so much.
today.
Thank you so much.
Thank you so much.
Yeah. Good evening to all the listeners and the viewers, those who are watching me here. I am here to present my presentation on the topic. Should I share my screen, ma'am?
Sure, sir. You are the co-host, so you can share.
Yeah, just let me know if it is visible, right?
Okay, sure.
Is it visible, ma'am?
Yes, yes.
Okay. So without taking much of your time, I'm so much happy to for the participants and the viewers, those who have been here. So my topic for today is diabetes mellitus and how we can integrate diabetes with organon of medicine, homeopathic materia medica, and the repertory and the case taking. So just let's start with the session. Diabetes. What diabetes is actually, as all of us know, the diabetes, it's a group of disease. It is not a single entity where we have the high blood pressure. The high blood pressure is there, and the high blood sugar is also been there, and it is there for the prolonged time. And when the patient is coming to us, we see in him or her the symptoms of high blood sugar, and there's increased frequency of urination, there's increased thirst, and many a times the patient is having increased hunger. So diabetes, it is either due to the pancreas are not been producing enough of insulin, or the it becomes insulin resistance many at times, which goes for the second type of diabetes mellitus. So in the totality, we have three types of diabetes mellitus. Type 1 diabetes, that is the insulin dependent diabetes mellitus, IDDM. Second is the type 2 diabetes, which is the non-insulin dependent diabetes mellitus. Third is the gestational diabetes, which is seen usually in the pregnant woman during the period of pregnancy. So what happens in the type 1 diabetes mellitus? In type 1, the pancreas, they fail to produce the sufficient amount of insulin. And that's why it was been previously they called it as the insulin dependent diabetes mellitus, and it is usually seen in the young age in the children and all, and that's why the other name is the juvenile diabetes also. The cause is not known, but some autoimmune disorders have been related with it. We'll see that in the next slide. Coming on to the second, that is the type 2 diabetes, where it begins with the insulin resistance, where there is production of insulin is there, but it has not been absorbed properly by the tissues, and it remains there only. So the level of glucose within the blood, it goes on rising and rising, and we have the hyperglycemia. Then this form, it was previously, as the earlier was the insulin dependent, here it is called as the non-insulin dependent diabetes mellitus, but still we require insulin for it. So as a mode of treatment, they administer insulin. Then we have the third one, that is the gestational type of diabetes, and it occurs usually in the woman, and they are not having any kind of history of diabetes mellitus. And when we go for the comparison between type 1 and type 2 diabetes mellitus, here I have the chart for it. Regarding the onset of type 1, it occurs all of a sudden. And in the type 2, it takes time, so it is very insidious and gradual. And the age in type 1, it is usually seen in the children, and type 2, it is seen in adults, old age. How's the body size in type 1? As the person is thin or normal. And in type 2, it is obese. Obesity is one of the risk factors to have diabetes, type 2 diabetes. Ketoacidosis, mostly it is seen in the type 1 complications, and type 2, it's rare, but if having a longer duration of type 2 diabetes, those persons can also have the ketoacidosis as the complications. The autoantibodies, type 1, the uh, exact cause for that is not known, but many a time they say, okay, the type 1 is because of the autoimmune disorder where the beta cells get destroyed and there's no insulin. And in type 2, there's no such kind of auto antibodies. Endogenous insulin. In the type 1, it is low or absent, and in the type 2, it is normal, decreased, or increased. Then when we see the twins, the concordance with the twins, in type 1, it is 50% of the cases of the twins, they might suffer with type 1. And in type 2, it is said to be 90%. And the prevalence of type 1, it is 10%, and the type 2 is 90%. These are some of the signs and symptoms that we'll see in detail afterwards. So the classical, coming on to the clinical features, the classical symptoms, if the diabetes not been treated properly, it starts with weight loss. There is polyuria, there is polydipsia, and there is polyphagia. Polyuria means increased urination. Polydipsia means increased thirst. Polyphagia means increased hunger. The symptoms, they may occur rapidly within weeks or months, and in type 1 diabetes, while they usually develop much more slowly, and it is subtle and in the type 2. In addition to this, we also can encounter with the blurry vision, headache, fatigue, then the slow healing of the cuts. Itchy skin is also been there. They have been seen after a longer periods of diabetes. Then the person is having a prolonged high blood pressure, and that can cause the glucose absorption in the eyes, the lens of the eyes, which can cause some changes within the eyes. We have retinopathy and all. So it may lead to some kind of changes within the eyes, resulting in the vision changes. The person start with the blurred vision, and ultimately can land up into blindness totally. We can also see many of the skin rashes that occur in the diabetes, and those have been called as the diabetic dermatomes. The complications of diabetes, all the forms of diabetes, they increase the risk of long-term complication. They develop after a period of 10 to 20 years if a person is suffering with diabetes. Then going for the next 10 years or first 2 decades, then only they are going to develop the complications. So the complications can be divided into, if the complication starts in the larger vessels, we call that as the major vascular complications, which include the major organs like the kidney, the heart, and the eyes. Okay, so that is the macrovascular complications. Then we can have the microvascular complications where the minute arteries have been involved, the minute vessels have been involved, and they can be seen. It can affect the central nervous system. It can affect the eyes and all. Then we have the diabetes. It doubles the risk of cardiovascular diseases. Like I said, it is related with the heart disorders also. About 75% of the deaths in the diabetic, those are mainly due to the coronary artery disease. And then we have the macrovascular diseases. The person can suffer with stroke also, and then the peripheral vascular diseases. Then further going into the complications, the patient can feel numbness, tingling, pain. There's altered pain sensation, which leads to damage of the skin. Then the diabetic related food problems have also been there, where we call that as the diabetic foot, and the person develops ulcers over there. and it is difficult to treat them, and it requires the amputation. Most of the time, the person is not aware of he's having the gangrene and all, and it goes like that, and ultimately the time comes where it has to be amputated. Then we have the diabetic neuropathy. It is involving the nerves and all. It can cause the muscle wasting, weakness, and that has been called as diabetic myotrophy. Let's see the pathophysiology, what happens actually within at the cellular level. Insulin is supposed to be the principal hormone which regulates the glucose level within the blood, and the other hormone, which is the glucagon, which regulates or which balances the glucose level in the cellular level. So both of these are being required for the maintenance of the sugar on the blood sugar. So especially they have been targeting the liver, adipose tissue, and the muscles, in which the insulin is act via, we have one growth factor that is called as the insulin-like growth factor. It has been required for balancing or maintenance of the glucose level. And whenever there is deficiency of insulin, or when there is insensitivity of the receptors, then we see this in all forms of diabetes mellitus. The body is getting the glucose from different ways. The first is the intestinal absorption, whatever food we are having. From that, the insulin has been, we get the insulin. Then the glycogen gets broken up. There is breakdown of the glycogen, and the storage form of glucose, it is found in the liver. So glycogen can be broken down and it can be formed into glucose. Then we have the gluconeogenesis, where the new glucose molecules have been formed, and this gluconeogenesis process, it is been done from the non-carbohydrate products or the substances. The non-carbohydrate substances, like the fats, like the amino acids, they get broken down into glucose, and that process is called as gluconeogenesis. After that, if the amount of insulin which is available, if it is not sufficient to maintain the blood sugar level, then the cellular response, it is poorly to the effect of insulin, and the insulin itself is defective. Then the glucose will not absorb properly by the body. The net effect is the persistent high level of blood glucose level, and when the glucose level is increased in the blood, the protein synthesis is poor, and the breakdown of the fat, it also becomes very much poor. When the glucose concentration in the blood, it remains higher for the longer duration, or for more time, then the kidneys, they will reach up to the threshold of reabsorption, where they are not going to absorb the glucose, and they throw the glucose into the urine, leading to glycosuria. So the urine contains the glucose. The increase in the, then this leads to increase in the osmotic pressure of the urine, and when the osmotic pressure is increased, it leads to polyuria. Then when it is leading to polyuria, fluid loss has been there, and to maintain this fluid loss, the blood volume, it has to be replaced osmotically from water held in the body cells and the other body compartments. So whatever water is there, it has been churned up. It leads to dehydration, and when there is dehydration, the person becomes very much thirsty, leading to polydipsia. Let's see the pathophysiology of type 1. In the type 1 diabetes, it is usually characterized by the loss of the insulin producing beta cells, which are present in the islet of Langerhans, and it is leading to the insulin deficiency. Like I said before, the majority of type 1, it is immune mediated, in which the T cells, they target they attack the beta cells, or we have the loss of the beta cells. And when there are no beta cells, actually the T cell, they start destroying the beta cells of islet of Langerhans, and hence we don't have any kind of insulin which has to be produced. So it leads to deficiency of insulin, or total loss of insulin. So most affected people, they are healthy and a healthy weight when the onset has been occurring. The sensitivity and responsiveness to insulin, they are usually normal, especially in the early stages. Type 1 diabetes mellitus, it can affect the children or the adults, and that's why it was been called as the juvenile diabetes. But nowadays, majority of the case, in earlier it was majority been seen in the children only. So that was about the type 1 diabetes. Now moving further, we have type 2 diabetes, uh, which is nothing but the insulin resistant type of diabetes. It is also been called as uh, non-insulin dependent diabetes mellitus, NIDDM. The defective responsiveness of the body tissue to the insulin, it is believed to involve the insulin receptors. So we have the insulin receptors on the cell which are going to absorb. Okay, so this becomes unresponsive, and in the early stages of the type 2, the predominant abnormality, it is reduced insulin sensitivity. But the type 2, it has also been associated with many of the risk factors or the lifestyle factors or genetics also. Then we have many of the lifestyle factors which can be predisposing factors to have diabetes, to the type 2 diabetes. Obesity, lack of physical activity, poor diet, stress. The dietary factors, they also influence the risk of developing the type 2 diabetes. If the person is consuming the drinks which are very much sugar sweetened, and the types of fat in the diet, it can be risk factor. The saturated fat, the trans fat, which increases the risk. We have the polyunsaturated and monosaturated fat, which can decrease the risk. Eating lots of white rice, it also may increase the risk of diabetes. Lack of exercise is believed to cause the 70% of the cases. So these are the risk factors. That was about type 2 diabetes. Moving further, we have the gestational diabetes. Gestational, the word itself is suggesting it is seen usually during the time of pregnancy, and it is almost looking like the type 2 diabetes mellitus. It involves the combination of inadequate insulin secretion and the responsiveness to the insulin. It occurs in 2 to 10% of the pregnancy, and it may improve or disappear after the delivery. But the child which is born during this period, but the child which is born out of this pregnancy, he is suffering many of the deformities. However, after the pregnancy, 5 to 10% of the women with the gestational diabetes, they are found to have diabetes mellitus, and mostly it is type 2 diabetes mellitus. It is totally treatable, but it requires a lot of supervision. Medical supervision is required throughout the pregnancy. And the management, it may include dietary changes, blood glucose monitoring has to be done, and in some cases, insulin may be required as the case is demanding. What is the pathophysiology behind this gestation? It is transient, untreated gestational diabetes. It can damage the health of the fetus or the mother. So we have the damages on both the sides, on the maternal side and on the fetal side also. If the baby is born, the baby is having the very high birth weight, that we call it as macrosomia, and may suffer with congenital heart defects. There are central nervous system abnormalities, skeletal muscles malformation can be seen, and there is increased level of insulin in the fetus. It may inhibit the fetal surfactant production, which can cause one syndrome, that is the respiratory distress syndrome. A high blood bilirubin level may be seen when they have the increased destruction of the RBCs, that is going to liberate more amount of bilirubin. And in severe cases, the baby may die, that is the perinatal death. It may occur most commonly as a result of poor placental perfusion due to vascular impairment. If the pregnancy continues like that, the labor it may be there is labor induction, and with decreased placental function, the lady has to undergo cesarean section. If there is fetal distress, increased risk of injury associated with macrosomia and the shoulder dystocia. What are the clinical features of gestational diabetes mellitus? There is hyperglycemia, glycosuria, polyuria, polydipsia, dehydration, loss of weight, poor resistance to the infection due to protein depletion. Actually, the gestational diabetes, it is because of one hormone that is called as the HCG, human chorionic gonadotropin hormone, which develops during the time of pregnancy, and it is having the effect to suppress the insulin. So the insulin is not doing its work properly. So that's why gestational diabetes occurs. Moving up to the investigations, the laboratory investigations, we need to go for the blood sugar level, the fasting blood sugar level, a postprandial blood sugar level, a random blood sugar level. We'll have to go for the HbA1c level, the C peptide level, glucose tolerance test that has to be done, and in the urine analysis, the presence of glucose in the urine, the ketone bodies, everything has to be done. So the first one is the fasting plasma glucose, which is the basic and very important. That goes for FPG. It is useful for both diagnosis and the follow-up. If the patient is diagnosed with this, we can go for the follow-up, and after administering a proper amount of insulin to the patient, the level can be maintained. When performing the blood collection for this, special attention has to be given to the patient, and to the patient, they might develop severe hypoglycemia, which might lead to sudden death or the blood collection. So that has to be seen what we are administering to the patient. If there is very high risk for diabetic patient who are fasting, but still they are using the insulin injection, so special concern should be provided for such cases. And focusing on the blood collection tube, the sodium fluoride tube, the gray stopper must be selected properly. However, in the case that the fasting glucose, it is co-ordered with the other basic clinical chemistry tests, plasma, the red stopper tube, everything has to be correlated with one another. Then coming on to the next investigation, we have the capillary glucose determination. That is the normal glucometer which we use in every household nowadays. We have this glucometer, and by that we can see the level of glucose. The capillary glucose determination by the glucometer, it is accepted as a very useful tool in monitoring the diabetes mellitus case. It is accepted at the most widely used point of K testing at present. This can shorten the turnaround time for the laboratory analysis. The bedside test can be done. It is present widely used in the ward's emergency room for the fast results and indicated for the scenario that requires the prompt decision for managing the diabetes mellitus patient. In conditions like the patient is unconscious, which might be due to hypoglycemia or hyperglycemia. So in such cases, we can very easily record the level of sugar with this instrument. In addition, the glucometer, it is also already been considered as an extended indicator for the other purposes. It is presently applied as the daily self-monitoring tool for diabetic patients. Next investigation is the postprandial glucose. It is an alternative measurement for the blood pressure. That is, sometimes when the fasting glucose level is not feasible, we go for the postprandial glucose level. And this might be another alternative method for the diagnosis. One who is with the abnormal high postprandial glucose level, it needs the further verification by the fasting glucose level. The postprandial glucose, it is an actual application of measurement of chemical in the blood with the interferences with the diet. However, the practical problem in usage of postprandial glucose, it is difficult in setting for the accurate cutoff point in the abnormality. And for some instances, control of the diet intake, the setting of the time can be useful for application in the diagnosis. This is the concept of glucose challenge test and the oral glucose tolerance test, which are widely used in the obstetrics. Next, moving on to the glycated end product tool for monitoring the diabetic complications. So this is the glycated hemoglobin. The glycated hemoglobin is what? The hemoglobin which contains the glucose molecules. Usually, the hemoglobin molecule, it is not attached with the glucose molecule. But if the concentration of glucose, it gets increased within the blood, all the glucose molecules will get attracted, they will get adhered to the hemoglobin molecule, and they will glycate the hemoglobin molecule, and that can be estimated. The glycated end product, it is specific in the in vivo substance that can be generated in case of poorly controlled diabetes mellitus patient. So this is the result from the reaction between proteins in the blood, normally the hemoglobin or the albumin, with excessive glucose in the blood. The nature of energy aberration induction of the reaction results in complication of diabetes. The two tests on the glycated end product, they are the hemoglobin A1C, that is HbA1c, and the other is the fructosamine. The HbA1c, it has a wide range of prediction up to 3 months, while the fructosamine is for 1 month. HbA1c should be carefully interpreted in the setting with the high prevalence of hemoglobinopathies, because this can deviate the result. In addition to the two quoted tests, the glycoalbumin test is also available. So the normal range for this HbA1c, it is less than 6%. If the person is the diabetic patient, so it can go for more than 6.5%. So that can be the pre-diabetic, diabetic, or the post-diabetic patient, depending on the level of HbA1c. So this test has to be repeated for every 3 months, and the average has to be taken, and the level of the glucose should be monitored properly. Usually HbA1c test, it has been done in the complicated cases of diabetes mellitus, or in the cases of diabetes mellitus where the fasting blood sugar and the postprandial blood sugar level are normal. Still the person is having the symptoms of diabetes mellitus, still the person is having many of the complications. Then we go for the HbA1c, that is the glycated hemoglobin. Now coming on to the next, that is the glucose tolerance test, GTT. It has been done in two ways. One is the intravenous GTT, the other one is the OTT, that is the oral glucose tolerance test. And this is the test usually done in during the period of pregnancy, where a specific endocrine disorder in the obstetric is generally indicated after positive urine glucose test and the glucose challenge test. So when the woman is showing glucose in the urine during the time of pregnancy, then we go for this test, that is the oral glucose tolerance test. Hypoglycemia can still be detectable during OGTT, that is the oral glucose challenge test. Some pregnant cases might have hyper MSS gravidarum, which might lead to abnormal low resulted glucose levels. For collection of the blood, the order of the collected samples must be gently controlled, because alteration of the order can make a total difference in the interpretation. So what do we do actually in the glucose tolerance test? We keep the patient nil by mouth for the previous 8 hours, and after 8 hours, when the patient is coming to a lab or into a clinic, we ask the person to consume some amount of glucose. It can range from 75 grams to 50 grams depending on the demand. So we give 75 grams of glucose orally to the patient, and we see the level of glucose level after 2 hours of consuming the glucose. And again, we repeat the same thing and we see the level of glucose after 1 hour. So this has been repeated, and we see how much the level of glucose is there when we give the glucose orally. We also have the urine test for diabetes. The urine glucose test, it is the old classical test for the diabetes mellitus. This is the Benedict test which I am talking about. In the past, it was primarily observed that diabetes cases usually avoided the urine contaminated with sugar, and this is the basic concept for usage of urine glucose test. This test is nowadays we don't go because many new have been there, new investigations have come into existence. The new test is the microalbuminuria test, where the urine contains the albumins. So it has been determination of the micro quantity of albumin in the urine sample. The positive microalbuminuria, it means the glomerular pathology, which is common complication of diabetes mellitus. However, the positive microalbuminuria can also be detectable in the other medical disorders like hypertension, which usually corresponds with the diabetes mellitus. Next, we have the ketone bodies in the urine. That is the urine ketone and the blood ketone tool for diagnosis of the diabetic ketoacidosis. So this diabetic ketoacidosis is one of the complication of diabetes mellitus, where the person starts excreting the ketone bodies in the urine. Okay, so the hyperglycemia, it is one of the very much important complication of diabetes mellitus, and hyperglycemia it leads to diabetic ketoacidosis. And diabetic ketoacidosis is seen more in the type 1 diabetes mellitus as compared to type 2. We can see this in type 2 also, but it takes lot of years to develop the ketoacidosis in type 2. Okay, so there is hyperglycemia, hyperosmolality is there, and we can see the accumulation of ketones in the body of the patient. And these ketones, they have been washed up. Means when the person is breathing out, we can smell a very sweetish smell. That is the Kusuma's breathing, we call it as usually. So the patient usually present quick respiration, and there is a basic test, the plasma glucose determination. It is useful for the diagnosis of high blood sugar level, but it is unable to definitely diagnose the ketosis. Then we can go for the electrolyte imbalance. There is increase in the burn, and it has been observed due to the hyperosmolarity, but they cannot lead to definite diagnosis of diabetes ketoacidosis. The definite diagnosis of ketoacidosis, it is based on determination of the ketones in the urine. Okay, if we find some kind of ketone bodies within the urine, like the beta butyric acid and all, so that is significance of ketoacidosis. Then very special type of investigation is now into existence, that has been called as the C-peptide. The C-peptide, now what this C-peptide is? C-peptide is one of the hormone, and which is present before the formation of insulin. So before the insulin, we have the pro-insulin, and the insulin molecule, it is having different chains like the alpha chains and beta chains. And what this C-peptide is doing, it is attaching one alpha chain with the beta chain of the insulin, so that more the C-peptide, more the insulin level. Okay, so if we see the peptide level, C-peptide within the blood, that is the level of C-peptide, whether it is decrease or whether it increase, it is going to show you the level of sugar in the blood. Okay, so it is one of the very new tests in the diabetic medicines. It is mentioned useful in the follow-up of the diabetic complications. The level is very high if the patient is suffering with diabetes, and the level goes on lowering down if we are giving a proper medicine to the patient. It is noted for the good diagnostic property for the diabetic neuropathy, one of the most common complication of diabetes mellitus. And the peptide, it was a very simple kind of chain, cost effective. It is non-invasive method in assessment of the beta cell capacity. However, the main limitation for C-peptide test is it is very expensive test, and the availability is also very much not that much available. Okay, so coming on to the next investigation, we have the insulin test, which is the direct measurement of the hormone. We can measure directly the level of the hormone. The insulin, it is a major hormone which is there for the regulation of the blood glucose in the hemostasis. It has been required. The abnormality of the insulin physiology, it is important, as I have already illustrated in the previous slides. The measurement of insulin, it can be done, but it is not particularly used in routine diabetic clinic. In addition to simple insulin level measurement, the glucose clamp technique has been done, where the hyperinsulinemic eugenic clamp is assessing in the vivo insulin sensitivity, and the hyperglycemic clamp, it is assessing the insulin secretion. It has also been performed to measure the insulin secretion and the sensitivity. The principle of this technique is to open the hemostatic feedback loop, and this technique is useful to accurate assessment of the beta cell function. And for sure, the clamp technique is difficult and should be performed by experts in the diabetic medicine. So nothing much for this. Coming on to the homeopathic part of, now let's see the integration of diabetes mellitus in respect to our homeopathic subjects. Let's see the miasmatic evolution, how it has been related with the miasms. Coming to the first one, we have the soric phase. So what all changes we see in diabetes in the soric phase? It is usually related with the functional stage. It is the earliest stage, the functional imbalance we see, and irreversibility we see. Okay. The key features, what all we see in as a soric miasm. There is disturbed carbohydrate metabolism without permanent changes. Fluctuating blood sugar has been seen. There is polyuria, polydipsia, polyphagia. All three P's are been covered in this. Nervous excitability is there. Patient is anxious. Anxiety is there. A thin, emaciated, lean patients. Skin itching. Eruption suppressed. The dominant remedies for this miasm: sulfur, lycopodium, phosphorus, there is natramure, and calcarea carb. What is the interpretation behind this? The soric miasm, it shows functional disturbances reflecting the beginning strain on the pancreas or the insulin pathways. So that was about the soric miasm. Moving on to the next one, the psychotic miasm. Psychotic, it has been related with the structural and the metabolic dysfunctions. So it has been seen in the progressive stage, where there is compensation, insulin resistance has been there. I mean the type 2 diabetes mellitus. The key features for this, there is weight gain, obesity, insulin resistance, hyperinsulinemia, polycystic ovarian syndrome, PCOS, in some of the females. We see warts, skin tags have been seen, edema, water retention, hypertension, dyslipidemia, slow metabolism, emotional suppression, fixed habits. What are the dominant remedies for this? Thuja, natrum sulph, medorinum, graphitis, and causticum. How do we interpret this? Psychosis, it has been linked up with the overgrowth, excess, retention, matching the metabolic syndrome picture associated with type 2 diabetes mellitus. Then the next miasm, we have the syphilitic miasm. In the syphilitic miasm, there is degenerative and destructive stages. Okay, so when the person is in the complicated type, he underwent the complication of diabetes mellitus. That means he has jumped into the syphilitic miasm. And it is seen in the late stage, where there is degenerative and destructive stages. We see irreversible pathology has stuck in, and the complications have been faced up. So the key features for this, all the complications which I uttered earlier: neuropathy, there's burning of the hands and the feet, retinopathy, vision loss has been there, nephropathy, renal failure, non-healing ulcers, gangrenes, atherosclerosis, myocardial infarctions, strokes. There is tissue destruction, vascular degeneration, loss of sensations, and the amputation tendencies. If we see all this, then that is directing towards the syphilitic miasm. Dominant remedies for this: syphilinum, aurum metallicum, Merxol, arsenicum album, Cicalcor, lacasis. Interpretation for syphilitic miasm, it corresponds with the degeneration, ulceration, necrosis, and the hallmark of the chronic diabetic complications. Then there is tubercular miasm. Tubercular miasm is mix-up of these miasms. It is seen in the intercurrent phases in between. Like the dynamic miasms, it oscillates between the sora and the syphilis. The key features for this, when we see the sudden swings of the blood sugar, sometimes it is very high, sometimes it is very less, then that is the tubercular miasm. And again, there is weight loss in spite of having a good food, good appetite, still the patient is not gaining the weight properly. Weakness, fatigue is there. Respiratory complaints we see. Then there is family history of tuberculosis or wasting diseases. Nervous irritability, restlessness, rapid tissue breakdown has been there. What are the dominant remedies here? Tuberculinum, phosphorus, iodum, calcarea phos, and ignitia. How do we interpret this? Tubercular influence indicates the instability and rapid change and may complicate type 1 diabetes or the brittle diabetes. Let's see the homeopathic drugs which have been indicated. All of us know the best drug which has been indicated, that is the Cytogen Jambolinum. And the onset, one of the most frequent used remedies for glycosuria, reported in the Materia Medica to help to reduce the sugar levels. It is indicated in intense thirst, polyuria, and diabetic foot. Next is phosphoric acid. Diabetes from grief, loss, mental exhaustion, profound weakness, apathy, indifference in the early stages. There is copious urination with milky appearance. Next is phosphorus. In phosphorus, we see burning sensation, there is thirst for cold water, weakness, weight loss, hemorrhagic tendencies with nephropathy. Next, we have lycopodium. And there's diabetes with gastric trouble, flatulency. There's worsening of the complaints during 4 to 8 p.m., craving for sweets, weak digestion, and liver involvement. Sulfur, it is indicated in the long-standing diabetes, skin problems, burning soles, diabetic neuropathy with hot feet, deep-acting constitutional remedy. It is one of that one. Arsenicum album, it is seen in the restlessness, anxiety, there's intense thirst for small sips of water, there's prostration, burning pains. It is useful in the complications like diabetic gangrene. Next, we have Natrum miraticum, diabetics, which is linked to emotional suppressors. There is silent grief, craving salt, headache, and emaciation. Then we have uranium nitricum. Uranium nitricum, it is considered in the severe glycosuria, polyuria, polydipsia. There is weight loss and debility. It acts on the pancreas and the kidney. Then we have Cephalendra indica. There is excessive thirst, dryness of mouth, helps regulate the blood glucose. It is useful in fatigue and weight loss. Let's see some of the rubrics from the Kent's repertory. It has been given the general rubrics, generals, diabetes / diabetes mellitus. The rubrics which have been related to polyuria, we have bladder, urination, frequent, night, bladder, urination, profuse, bladder, urination, increased, diabetes in. The rubrics for thirst, stomach, thirst, excessive, stomach, thirst, unquenchable, constant, stomach, thirst, night. Then we have the rubrics for appetite, stomach, appetite, increased, diabetes in, stomach, hunger, ravenous with emaciation, sugar in urine, glycosuria. That is, we see this in bladder, urine, sugar. The rubrics for weakness and debility, generals, weakness, diabetes from, generals, emaciation, diabetes in. And for mental symptoms, we have mind, grief, and ailments from. So this was a short about the diabetes mellitus in respect to the 3 pillars of homeopathy.
Thank you so much, sir. You have explained everything about diabetes.
Yeah, ma'am.
Uh, Thank you so much for the detailed class, even the investigation and medicine. Thank you so much. I think the participants will have, you can stop the slide sharing. So it will be,
Okay. Is it good now?
yeah.
Okay.
If the participants have any question regarding this, Dr. Beatrix, I'm seeing you for after long break, right? Okay, you can ask. You can unmute yourself.
Yes, thank you. Thank you very much. And congratulations for the very, very good presentation, as the topic is so complex. I
Yeah.
think we would be interesting to have perhaps another session with cases of your experience and of your practice. So my would be very nice. So my concrete question is, I have several questions to be honest, because it's an important topic. One question is, did you experience to be able to cure diabetes 1 in little children?
No, I'm not. I was not that much fortunate to treat in children. I have treated the adult one. I have almost, after giving the prescriptions, after giving the medicines, I have lowered their sugar level many at times, but not in the children's or in the infants and all.
Yes, thank you, because it's not an easy
It's
situation.
not easy. Yeah.
Yeah, I understand. And next question. What I see here, I'm talking from Germany, and
Yeah.
what I see here in the last 5 years, more or less, that the woman in pregnancy, also the pregnant woman, they
Yeah.
seem to be controlled more about the blood sugar, and quite often they tell them you have diabetes, you have to be controlled, tuck, tuck, tuck. But it's a normal pregnancy, nothing is happening. So it's a kind of over alertness here in Germany, I feel,
Yeah.
concerning the pregnant woman, which also makes them a bit anxious and being afraid that something is not correct. Do you have that experience also?
Ma'am, with all due respect, uh, the gestational diabetes, many a times it is there for the period of that gestation. And once the
Yes,
woman delivers, she is okay with it. But
yes,
if the child is born with that, the child is having more difficulty. As I have said, macrosomia has been there. The baby is born, a big baby has been born, and that can be related with every structure of the body. The heart is involved in that, so all the modalities, all the abnormalities are there, we see in the baby which has been born. That can happen if the sugar is not been controlled during the gestational period. If we control it during that period, the baby is born normal only. So that
yes.
has to be monitored throughout the semesters.
Yes, yes. Thank you very much. I totally agree. But what I see here in Germany is, and that always has been like this, that's natural. But if the blood sugar is just a bit elevated, it's a big stress in the whole situation for the doctor, for the
For
family.
everyone, it's a
So,
stress.
mhm. Yes,
Yeah.
that's my question. Thank you so much for your experience and your presentation.
Thank you, ma'am. I'm obliged.
Thank you, Dr. Beatrix. And Dr. Danish, you can ask.
Uh, Thank you, Dr. Shailendra Bhamar. It's really a very good session. You really covered all part of this
Thank
diabetes.
you, sir. All due respect.
And, yes, we will have to think about the mechanism and how one we can manage. But the most important point I would like to add to this session is that we will have to look into the constitution of the patient, so that if you are
Yeah,
choosing
that's correct, sir.
if you're able to choose the right constitutional remedy, that will work at all times. But the thing is that most of the patients used to visit us when they are taking allopathic medicine. Then we will have to the correction will be a little bit difficult for us. But along with the allopathic medicine, if we give homeopathic medicine, we can reduce the intake of allopathic medicine and gradually
Certainly,
that
certainly.
that's what we have noted. Then, to other question Dr. Beatrice put forward was that about the pregnancy gestation and how we can manage the situation with homeopathy. For example, I have a case of a lady. She used to have this diabetes every time, very much high. So that the doctors was because she had two deliveries, and but still she would like to have one more delivery, but the doctors advise better not to take because of both times it was very high, and she was managed with the insulin therapy during the pregnancy. So what I found that there was a lot of issues where the family, and because of that, her pregnancy period was full of problems, and because of that, she wouldn't take proper food and proper rest, as well as she was totally mentally upset. So the what I found that there was a big problem with the family, and the what I found the medicine was the Ignatia, and I just gave her Ignatia tenum. Though in the first I gave her Ignatia, that works wonderfully, and later she up to the fifth month there was no diabetes, but once it started again we give Ignatia tenum. And the doctor, the gynecologist asked her whether you are taking insulin or not, like that. Then she told that doctor, I am taking homeopathic medicine. Then
Okay,
she
nice.
continued the same medicine, and after 2 months, her diabetes was back to normal. She delivered a child without any problem. Not only that, she told me that that was the first time she enjoyed the beauty of pregnancy.
That's nice.
Nice, very
Actually,
nice.
Nice.
actually, as Dr. Beatrix said, the stress everyone gives makes them diabetic because of that stress and fear it
Yeah,
became a cause of
Yes,
diabetes.
it is one of the risk factor.
Yeah,
yes. People used to say that the food is the number one cause. No, food is
yeah.
secondary. Food is a secondary. But actually, the problem within the person or within the
Yeah,
family, that may
because
be
of
the
that fear, no?
yes, that may be the precipitating cause for this the so-called diabetes, and then only the food will make problems. Actually, that's what I would like to
Sir,
add.
Tessiton Illeri, you
Yes,
can
yes.
ask now.
Thank you very much for this nice presentation. My
Thank you.
question is like this: for adult cases, type 1 diabetes diagnosis is made nearly healthy people, but with some stress factor, quickly diagnosis is made you are type 1. At the beginning, what is your treatment before starting insulin? What is your advice? Or
I didn't got your words, sir. Sorry.
sorry,
I didn't got your words, sir. Can you repeat, sir?
for an adult, when type 1 diabetes diagnosis is made, here quickly insulin is started. At the beginning stage, what can be made homeopathically?
Homeopathically. So we'll go for the individualization. We go for the constitutional remedy, whatever has been there, and that is going to give you the exact medicine. And if we go for the complications of this, we have MODY, MODY, and we have the LADA, LADA. So latent autoimmune disorder in the youngs, and that MODY is there. the maturity onset of diabetes in the youngs. So they are the modified form of type 1 diabetes and type 2 diabetes. Usually type 1, it is seen in the younger age group. If we see that in the adult one, that is the modified form of type 1 diabetes.
What is your treatment for insulin regulation?
So again, I said we'll go for the individualization. We see whole of the case. We'll go for the constitutional remedy, and depending on the physical makeup, the mental makeup, we'll come on to the diagnosis. And we'll evaluate the symptoms, and then we'll come to the final medicine, sir.
Okay, thank you very much.
Thank you so much, sir.
Yes, for instance, to give an example, I just 2 weeks ago, I had a little boy, 7 years, with a new diabetes 1. The mother also has diabetes, is a slim person. So the problem of the child was that he was going into hypoglycemia. He is doing sports, football, and the mother has to stand at the side to give him food because he's moving so much and the sugar is going down very quickly. So what I did as a constitutional remedy, I gave him phosphorus, C30, once a week, only once a week in the beginning. And I got the feedback yesterday that the boy is much better during the sport, 1.5 hours sport, and the mother can sit quietly and everything is regulating a bit. So let's see what we can do for that boy.
Yeah.
So I think now we have 2 minutes more. I'm inviting Dr. Bob Lim for giving out of thanks to Dr. Shailendra. You're welcome, please. Dr.
Thank
Bob
you.
Lim, if you have any question also, you can ask. You have 2 minutes.
So you can ask questions if you have any, sir.
Oh, I have only 2 minutes to ask question and to say a lot of thanks. I'd like to ask you whether you've experienced before when the patient diabetics is taking medication, does it been an obstacle towards cure if they are taking allopathic medication at the same time as taking homeopathy? Will this slow down the process of the cure?
Yes, it's an obstacle, certainly, because we'll not able to come to know whether the level of blood sugar has been lowered because of allopathic or homeopathic. We are not going to know about that. If we are stopping the allopathic medicines and going for the homeopathic treatment, and then it has been giving the result, then we can say that the homeopathic medicine has reduced the blood sugar level. But if the patient is continuously taking the allopathic medicine like the metformin and all they are taking, so it may be because of that drug, the level has been maintained, so like that. So it should be stopped at first.
Okay, thank you very much. But I'd like to share a case in which I treated my elderly mother for a wound that stubborn wound that wouldn't heal. So I told her to stop all allopathic medications and ointments and this.
We have to do it.
Her with homeopathy, cysticium, and also calendula, and surprisingly, treatment and she recovered from the wound, and also she recovered from diabetes. So that is the case. And thank you very much.
You have to stop the allopathic medicines. Then only homeopathy will work, or it will alter the treatment.
Then it will help. Thank you very much, Professor Dr. Shailendra, for tonight's.
Thank you so much, sir. Thank you so much.
Thank you, everyone. Dr. Danish, have you raised your hand again, or?
Yes. We have an announcement for tomorrow. Tomorrow, another doctor from LR Homeopathic Medical College is coming over here to deliver her presentation. That is Dr. Namrata Trivedi, and she is an assistant professor at the same college, and she will be talking about irregular menstruation, a holistic homeopathic perspective.
Okay, thank you, Dr. Danesh. Now we are moving to the Malayalam session. Thank you all the participants for joining with us. Love you all. Good night. See you the same time. Bye-bye. Thank you, Dr. Shailendra, again.
Thank you so much, ma'am. Thank you so much.
Thank you so much. And I'm inviting Dr. P. Shaila for moderating Malayalam session. Dr. Shaila, you're welcome.